So I'm looking forward to our EMface roundtable in a few minutes with many of my colleagues from around the country and around the globe. I'm Joel Cohn. I'm an aesthetic dermatologist in Denver, Colorado, and I was thrilled to be part of the EMface clinical trial. We treated 96 treatment sessions for the EMface clinical trial, and at this point in my clinical practice, we have over 400 treatment sessions that have been taken place. We've seen really nice results. We've seen patients who have really improvement in tone, and we see people who have improvement overall in volume as well by really lifting and suspending these areas of muscle and fascia and ligaments. When patients come to see me, they've made a decision to really think about aesthetic dermatology instead of having a facelift and a bigger surgical procedure. And like your practices out there, I use many of these technologies in combination and having a concert of different ways that we can improve the appearance of patients' skin, whether it's hyperfunctional musculature, whether it's volume loss, whether it's laxity, and then really dealing with some of the discoloration that people have as well as etched lines and wrinkles. So being able to address all 5 of those parameters is really important. And some people have more significant issues in one camp or another. And for our practice, EMface fits really in there for patients who have mild to moderate laxity that want to see improvement in that laxity. And we use these very frequently in concert with using injectables. So patients having neuromodulators to really relax some of these areas of hyperfunctional muscle, like in the glabella, and then people who have volume replacement needs. Sometimes that's laterally along the zygoma and the temple, along the jawline, or the anteromedial cheek.
Welcome to Art of Skin MD. I'm Dr. Melanie Palm. I'm medical director of this practice that's been here in Solana Beach about 12 years. I'm a board certified dermatologist and fellowship trained cosmetic surgeon. We perform a variety of activities here at the practice, from general dermatology to aesthetic medicine, and also have a research arm. Welcome to our non-invasive body contouring suite. This is our EMface device. We've had it since late 2022. And so far to date, we've administered 141 treatments. We have 34 patients in progress. So this is a very busy machine for our practice. And I'm going to do something special. We're going to talk about how I treat patients with me actually getting the procedure. So welcome back. It's after my clinic day, and I thought nothing better to actually describe EMface and how we're treating patients than maybe I'll be a patient myself. So in terms of EMface treatments, our flow for clinic is we actually conduct a consultation with me as well as our non-invasive body contouring specialist. The clinical studies demonstrated this once a week for 4 treatments. In clinical practice, we're finding that we really like results with about 6 treatments for our patients. And it can be administered once a week, but if patients have a compressed schedule, we can do this twice a week because the treatment parameters allow for treatment every 2 to 14 days. I try to catch patients before their redose for their botulinum toxin type A, especially in the upper face. And then in terms of injectables, most of our patients, I love this as combination. I try and do EMface first, see how this actually lifts some of the tissues. And then sometimes I think we can get away with more conservative injectable treatments. If we're doing it the same day, I typically will combine polylactic acid on the lateral face, but hold off on some of the hyaluronic acid fillers until a separate visit. And that's it in a nutshell. Thanks for joining us here at our clinic at Art of Skin MD.
Hi, I'm Sunil Chilakuri, a board-certified dermatologist in Houston, Texas. Thank you for joining me on this webinar. We're really just going to share some pearls and experience on how we've utilized the EMface in our practice. I have a purely aesthetic practice based in the center portion of Houston, Texas. We've had the EMface now for a little over a year, and we've performed approximately 675 treatments so far. The question that I often get posed is, how do we utilize this with neuromodulators, with fillers, with other energy-based devices? Very simply, When a person first comes in for a consultation, you want to evaluate what issue it is that's going to give them the biggest wow. When you're addressing that patient, you're going to use your smart fingers. You're going to figure out, is it skin laxity? Is it that there's muscle tone weakness that's pulling down? Is it that there's structural changes that are going on in that person's face? Review their photographs from when they were a child. Review their photographs from when they're a teen and a young adult so you can see what's changed over that time. In the past, we had great devices to recreate structure, to help redrape the skin a bit, but never anything that's going to tone the muscle, that's going to help us lift up where the cheek sits, lift up that brow position, unless we turn to surgical options. Those surgical options, also known as rhytidectomy, would allow us to then reflect the skin, take that muscle, shorten it either by sewing it to each other or to lift it up and replace it, performing what's often called a deep plane rhytidectomy or deep plane facelift. I almost never have to go to that route immediately anymore unless somebody has significant laxity, has significant jowl positioning. For those patients who are in their 30s, 40s, 50s, and 60s who are just starting to see signs of aging, you have to address what's going on in that particular person. If we see, especially in their 40s and 50s, they're just getting a little bit of that jowling, they look down and everything kind of sags a little bit, we look at replacing or strengthening that muscle. That's going to help us lift with resting tone here, or in those cases where they have a lower set brow genetically, we can reset where that brow sits by using something that's going to strengthen the muscle. That's where our EMface comes into play. So with the EMface, we're going to actually strengthen that muscle, improve the resting tone. And if you're talking about the face, so the cheeks, you're going to actually improve the resting tone of the zygomaticus facial major, the zygomaticus facial minor, as well as the rhizoris. And the rhizoris is what connects to the modialis that lets us lift up that corner of the mouth. As a result of repositioning or strengthening those muscles, you're going to find that there's a secondary benefit for the jawline as well as a portion of the neck. When you combine the cheeks along with the frontalis muscle, so addressing up here, not only are you improving the brow position, you're going to find that you're going to have some improvement, some periocular rhytids as well, both static as well as dynamic. Where do we add our neuromodulators and how do we make sure that it's not going to shorten the lifetime of our neuromodulators? Well, we do studies. So when we were studying this for the FDA, we were actually injecting neuromodulators. So you can pick your neuromodulator of choice. In this case, we have a lot that are back here. We have the classic Botox, we have Dysport, we have Xeomin, and we have the latest, Daxxify. So in this case with the FDA trial, we were able to inject and we had to wait 10 to 14 days before we apply the EMface. The purpose of the study was just to see, is the EMface going to change or shorten the duration of that neuromodulator? And we found wholeheartedly 100% no. It does not change the effectiveness of your neuromodulator. Same thing, we're starting a study now combining this with fillers. Does it get to a temperature where you can adjust or break down the filler? Theoretically, there should be absolutely no chance of that. Why? We're heating between 42 to 44 degrees maximum temperature, and it's more superficial that we're applying this temperature with the radiofrequency. The melting point for most of these fillers is going to be above 150 degrees Celsius, so we're not even in that range. That being said, how do I utilize this in my practice? If somebody has a structural issue along with the muscle issue, I'm going to replace the structure at the same time as my EMface. So for instance, if you have some hollowing of the temporal fat pad, which extends to the preauricular zone, as well as the platysma and the neck, I'm going to adjust here by putting what we need to for structural support in the temples. At that same visit, shortly after we finish our filler, I'm going to then add the EMface to then reposition and strengthen that muscle. I'm going to apply it to then apply to the forehead to improve the overall global aspect. At that same visit, pre-treatment with the EMface, if I need to address the jawline, let's say it's shorter, let's say the mandible doesn't extend to as far as we want it to, you can inject anteriorly and posteriorly to then extend and give the proper structural change. What position do we put this in? I do that first before applying the EMface. Why? I don't want the EMface to change any structural visibility that we see. I want to really place the product where I need it. How about in terms of neuromodulators? What's our order of action? In this case, I don't want the EMface or the radiofrequency and the muscle stimulation to affect where I place my Botox, Dysport, Xeomin, or Daxxify. So in this case, I'm going to actually apply the EMface first, and if they have deep etched in lines that are also more dynamic, I'm going to apply the EMface first. 20 minutes later, when they come off, then I'm going to go ahead and address which muscular component that we need to regulate the strength of that muscle. Where can we use this in combination? Well, again, oftentimes as people continue to mature, you're going to have some dropping of the brow because you have less resting tension of the frontalis muscle. But at the same time, I want to release the depressor muscles. So that's going to be your procerus, your corrugators, your bicularis oculi. So if I can release those muscles, my effect from the EMface is even greater. The second thing that happens, it doesn't cause more wrinkling. People say, oh, okay, you're going to activate the muscle. We've been telling people don't activate the muscle. That's what creates these static rhytids. In this case, you're actually improving the collagen and elastin health. So what we find, even if you're not using neuromodulators, you're going to find that the etched in lines, the static rhytids are actually improved. We see that the muscle tension is also improved. So as a result, the skin looks brighter. It looks like it's less wrinkled, and you have an overall improvement, even if you're not using your neuromodulators. How often do I then add something different? Well, it depends. Are you treating macular seborrheic keratoses? Can we use a picosecond laser? We have the Helios 4, we have the Piccolo. With those devices where you're using something to get rid of the macular seb care, I can do that immediately following my EMface treatment. Same treatment day, same treatment session. Or you can wait until the 4th treatment, 5th treatment, 6th treatment, and then go ahead and treat with that. Where do we add our chemical peels? Again, with this, I'm going to add it immediately after our EMface. Why? I don't want the heat that's being produced by the radiofrequency to drive in any more of that chemical peel. Also, when we put the adhesive pad for the EMface, I don't want that to be interfered by the chemical peel that's there. How about threads? That's another big topic. Where do we utilize that? I'm going to typically wait 3 to 4 months following my EMface, my energy-based devices, my neuromodulators, before I consider, do we need to add a thread? Unless it's the neck. If I'm trying to give a global home run, I'm going to go ahead and treat my EMface. I can do it the same day. I can do it at the end of the 4th treatment session, where I can put some structural support into the neck. And same thing, whether you're using a collagen stimulator like Radiesse, Sculptra, whatever you're doing on the neck, the HA that's hyperdilute, you can add at that time. Thanks again for joining me. I'm Sunil Chilakuri, Refresh Dermatology, Houston, Texas.
Hello, I am Dr. Nathalie Fournier from France, aesthetic dermatologist, and I have a laser center in the south of France for 25 years. It is full of devices with lasers, IPL, LED, radiofrequency, etc., etc. So when I heard about EMface, my personal question was, how can I introduce this device in my practice without harming the other devices? And so, especially with patients who have already been included in a usual procedure for them and recurrent treatments, I don't want to stop them doing that, of course. Also, the second question was, how can I do with the neurotoxin and the fillers? Because I don't want to stop the treatments with these products also. So this was really a big brainstorming about EMface. But then when I learned more about this device, I understood very quickly that, of course, it's not a competitor of these technologies. It is just the gateway for this technology procedure. And this is also the beginning of something for some patients who have never been in aesthetic, who do not want injection also. So how can it be at the center of your customized protocols for every patient? In fact, it's easy. Just examine your patient and see what you can offer with every patient. EMface plus, for instance, fractal CO2, radiofrequency, a little bit of fillers, a little bit of toxin. And in fact, it's a really easy game and it's very interesting. You examine your patient and you make a real personalized protocol for every single patient with EMface in the center of your treatment. And that will help people to go forward and to, because they have a maintenance treatment to do with EMface, to continue also the other treatments. So think about EMface like a gateway procedure for the other procedures.
Hey, this is Dr. Charles Boyd. I am a facial plastic surgeon, practice in Michigan, and I'm going to talk with you today about the EMface. So, my favorite, certainly one of my favorite devices, I think, of all time. I've had the pleasure of having this particular device in my practice for over a year. We've treated well over 200 patients with it. Talk a little bit about what I see as the advantages of EMface. So I think EMface, first of all, is good for my entire patient population. So my younger patients to my older patients can all find something that EMface helps and benefits them from. So as you know, EMface is a device that actually stimulates the facial musculature in the upper part of the face and the cheeks, and specifically more of the elevator muscles. So those are the muscles that lift up the cheeks, add volume back to the face, lift up the brow, and as we get older, all those things tend to lengthen and elongate. So having a device that can do those things is just amazing. And again, particularly for my younger patients where they're looking for more maintenance or prejuvenation, it's perfect for them. My middle patients in the middle age bracket, a lot of them like to do it even before fillers and Botox, and it's a perfect combination to do with those other things like any other non-invasive treatment. I think it works really well.
Those were nice videos. I think, Sunil, you answered so many questions that we're gonna borrow your script there. You went through everything, including chemical peels.
But it's all stuff that we all do in our clinics, right? Everybody who's joined us, I think we have almost 1,000 attendees. And, if you guys would grace me to allow to speak for all of us, we all use these tools in our practice. And the nice part about what every single person said is how are we utilizing with those other tools. Dr. Fournier, you really mentioned, you're using it in combination with your Fraxel, with your neuromodulators, your fillers. And that's what we do on a regular basis. Charles, you're talking about that every single one of our patients or potential patients is a client. Melanie, you were showing how you demonstrated on yourself. And it's all those things that we're doing in our practice on a daily basis. So you're very kind to say, Joel, but I think all of us are saying the same messages. This is one more tool that will allow us to enhance our scarless facelift.
We all have been using EMface in our practice for quite a while. Many of us participated in the clinical trial. So we began using EMface about 15 months ago. So we're going to talk about our experience and how we incorporate EMface in our practice. So I'll start with Dr. Fournier. What are the main benefits of EMface in your practice?
Well, in fact, first is the efficacy of the device. My patients are really pleased with the result. I have a very high index of satisfaction. Second, it's a non-invasive device. There is no pain, no side effects. It's delegable. It works on muscles, so it's something new that we offer because we had no machine for that on the face. And there is no season. You can do this during the summer, even if they are. And so, frankly, this is a real tool which is interesting for any patient in my clinic. And also we got reproducible results and on every patient. And this is a no knife and no needle.
technique also.
So speaking of the knife, Dr. Boyd, as a facial plastic surgeon in a busy practice, when you see a patient for consultation, a lot of times they're interested in surgery. But like our practices, sometimes somebody comes to you and says, look, I don't want to have surgery. I'm not a good surgical candidate. I don't want the downtime. I don't want the anesthesia. What are my options? How do you position EMface in your practice?
Yeah, thanks for the question, Joe. I think that, as a surgeon, and I think about even when I finished my training, at that time, every patient that came into my office wanted surgery or they got cut. And now we're at a point where most patients don't. And so I think this is a treatment that for the first time is doing some of the things that we do in surgery. So in surgery, I'm lifting the mass, tightening the muscles, and to be able to do that with a non-surgical technique with no downtime is really a game changer.
So, Dr. Palm, we've been speaking at meetings for several decades. I always like the way that you explain procedures to patients. And EMface is one of those areas where I think we really need to talk to patients and talk to them about how really the tone is established. So when you're positioning EMface in your practice and you're having a consultation with your patient, what are your really words of wisdom and how you explain it works?
I'd be really curious to hear from the other speakers as we go along too, but there's a movement happening, especially on the West Coast, where people are dissolving their fillers. They don't want an overfilled look. And so I find that a lot of my patients like the idea of something that's natural and using some of their own body to sort of rehabilitate. And I think that falls nicely into the story of sort of how I explain EMface. I mean, similar to Dr. Fournier, I say we've never had something short of surgery to really address the muscular compartment. We've had things that help this mass and tighten it up a little bit, but nothing that helps with hyperplasia and hypertrophy of some of the facial musculature. So I talk to them about this is kind of like rehab and PT for our face, that our muscles over time become more elongated. They sort of act as hammocks in our mid-face, and that becomes a little bit elongated. It doesn't function quite as well. And so this is an opportunity to sort of get in the gym, tone them again, work again a little bit against gravity, and have our own body sort of rehab and heal itself. And that's something very appealing to my patient population.
So regardless of what our practice is, from aesthetic physicians to aesthetic dermatologists to facial plastic and plastic surgeons and oculoplastic surgeons, I think neuromodulators are really a big part of all of our practices. And one of the concerns out there is really understanding how neuromodulators work and then how EMface works.
So the question is, does EMface negatively affect neurotoxin?
Right. How do you explain neuromodulators in the context of EMface, and then with Sunil's trial showing that they can work synergistically and patients can actually be even happier?
Okay. I tell the patient that first EMface will not interact badly with the neurotoxin because the device tone the muscle, but it does not make it contracted all the time. So of course it will not make bad mimics, because people think about like this, and so it will increase the tone, so it will help the elevation of the face. But if you relax the muscles, put down the eyebrows, of course the EMface will help to maybe put less units in the frontalis, and also helps to elevate eyebrows, especially to people who have very thin muscle frontalis. So I'll let Sunil finish the story about it, because he's better than me on that.
No, not better, not at all. All this
you did a better
concept. But it's interesting. Can you guys hear me now?
Yeah.
Can you give me a thumbs up if you can hear me? Okay, perfect. So several of the questions that came through here. Number one, can we use it with neuromodulators? What's the order that we go in with neuromodulators and fillers and things like that? So with this particular trial, we had to wait 10 to 14 days before we could treat somebody with the EMface. And this was 10 to 14 days after the neuromodulator. One of the plastic surgeons on here was asking, is it going to decrease the effectiveness of the neuromodulator, whether it's Botox, Dysprin, Jeuveau, or Xify here in the US? And the straight answer in 100% of the patients, no, it did not affect the longevity whatsoever. In terms of what order do we do it in, at least from our practice, if I have somebody who has etched in lines, I'm going to actually start with the neuromodulator, wait a week or two, and then apply the EMface. The other way to do it is if you have somebody who's coming from quite a distance, you can apply the EMface applicator, the frontalis applicator, as well as the cheeks if you need to. And then immediately following that first treatment session, you can inject the neuromodulator in a pattern that you normally would. In this case, typically, if we're injecting just based on the efficacy of the lift that you're going to see, the brow lift with the EMface applicator up there, I typically will release all of the depressor muscles. So we're going to release the procerus, the corrugator, the nasalis, as well as the bicularis. So if we just go in this pattern right through here, you'll notice that EMface is actually more effective in terms of the clinical results that the patient sees within 1 to 2 weeks. In terms of the efficacy and order, again, for fillers, I'm going to utilize the filler actually pre-treatment with EMface if I'm doing it for a structural component. So we know that the cheek applicator in particular is going to be affecting the zygomaticus facial major, the minor, and the rhizoris. All of those are elevation muscles. And how it works is by improving the muscle tone. For the plastic surgeon that was asking about the frontalis, how does it affect the frontalis and the neuromodulator? It's actually affecting the overall resting tone of the frontalis muscle. And with that increased tone, Sebastian Codofano, the anatomist, he's shown that we can actually keep that in a lifted position. In terms of the structural fillers that I'll put in at the same time, and actually I put it in prior to the treatment on the same day, is going to be the temple. Treat the temple. I'll treat the lateral subzygomatic area. So that's going to be in 2 of the fat pads. That can be the middle fat pad or as well as the subzygomatic lateral temporal fat pad that extends down.
I've done anatomic dissections with Dr. Boyd in the past. I've seen him do beautiful dissections. And Charles, can you talk us really through, when you approach a patient, you're looking at them and talking about blepharoplasty or brow lift. Talk to us about what you really think EMface is doing. Sunil mentioned the tone here, but you know, we have patients sometimes that have heaviness and brow ptosis after neuromodulators, and I've actually seen them look better and have less brow ptosis after EMface.
Yeah, there's no question. I think Joe, that's one of the things that impressed me most about EMface. So particularly in male patients, you know, we have a heavier brow that's typically lower, sitting right on the frontal bone or the orbital rim. And so those are the patients where, you know, their deep etched lines are really functional. So they have to raise their brows in order to get the brow to elevate. And so that's a patient where neuromodulators are actually doing the opposite of what they need. So we need a way to actually elevate the brow and shorten the frontalis muscle. And so other than surgery, there really was no way that I had to do that effectively. I mean, we had some things that would make smaller differences, but with EMface, and one of the patients that was actually in the trial is a male patient of mine, very deep rhytids in his forehead, and EMface was able to elevate the brow and with the radio frequency, decrease the lines without any neuromodulator. So I think that's really one of the things where it's super unique and can help most patients. And even patients that come in for a blepharoplasty, a lot of them have brow ptosis. And so if we can elevate the brow, we make the whole orbital complex look better.
There were a lot of questions about how many sessions we're doing, which I think would be great to hear from the other speakers too. Initially, we were recommending 4, which was consistent with all the clinical studies that were done. But in most of our patients 40 and over, we're really trying to do a package of 6. We're seeing even better results with those 6 treatments. There was a question about melasma and whether it makes it worse. That hasn't been studied, but you know, my feeling, and I see melasma several times a day with patients here in clinic, is, you know, heat and it causes inflammation. I see that with my hot yoga instructors and people that are doing that multiple times a day. So, it's not been studied. I have not seen worsening with melasma, but I think I would make sure that my patients that do have a history or have ongoing melasma are on active topical treatment that I consider gold standard, but I have not seen worsening or provocation of melasma with any of the patients that we've treated so far. In terms of schedule, the clinical studies conducted it once a week, 4 times. But it's FDA cleared for between 2 and 14 days. So yes, you can do compressed treatments. And we've definitely done that for out-of-state patients that are like zonies, which means they come here from Arizona to escape some of the hot weather. We've done it, every couple of days. I myself am one of those. But in terms of sort of the skin changes, we want to reach that happy temperature of about 42 degrees and have that sustained. I saw a question about, does this alter the fat, which is always a concern. I think with microfocused ultrasound and HIFU technologies, that's always a concern. And we're really just reaching the dermis. We're not reaching the subcutis or the subdermis. So fat adipolysis should not be an issue because of the superficial heat that we're causing. And pretty dramatic changes in collagen and elastin. So I believe the elastin increase is about 111% with those 4 treatments. And it's like 26 or 29% production increase in collagen. And I mean, I was at the AAD with many of you guys, our American Academy of Dermatology, a few weeks ago and was on several of the injectable panels. And my colleagues that are lecturing with me are like, what are you doing, Melanie? Like, you look great. And I haven't had injectables. I've just had I did 3 and then 3 about 2 months later. I just did EMface. And I mean, you can even see now on the display just quality of skin. That's something that I think sometimes isn't captured in photography, but definitely feedback we're getting from patients.
So sticking with the neuromodulator sort of category before we jump into other areas, first I just want to point out, you live in California. You mentioned there are people that do hot yoga more than once a day. I honestly, I haven't seen that yet. When I've done hot yoga once a week, I look emaciated here. But in terms of where we position these things in our practice, in terms of neuromodulators, Dr. Fournier, are you using neuromodulators in the same degree and the same dosage? Are you changing your overall approach to neuromodulators?
Well, in fact, I have the device for now 5 months only. I did about 400 patients, 400 treatments, and not 400 patients, unfortunately. And in fact, from the beginning, I tried to do the toxin 15 days before the first session of EMface, so I can make the control at 15 days and then begin the EMface session. For me, I could do for people who live far from my office, the session of toxin at after the first session of EMface. But I would wait because of the heat, I would wait at least half an hour before doing the toxin. About injection points, probably I will use less unit in the future, but for the moment I didn't change anything. I keep on with what I was doing formerly, just to see what was the difference. What I saw is that there is no difference. I mean, the toxin, the EMface has no negative effect on neurotoxin from my point of view. And so now I will think about maybe using less units, especially in the frontalis. But I will keep on for the corrugators and procerus, because of course, if you don't relax them, you won't get the elevation also. And one thing which is probably very good is that by doing a lot of sessions in the frontalis, you diminish the thickness of the frontalis. And so doing EMface, you will probably spare that, You will keep your frontalis active and you will keep the frontalis thick, which is good because the skin will not slide down. What we saw after years. So I think, yes, we can probably diminish the number of units.
This article really is a paper that's evolving right now that several of us have worked on really looking at the mechanism of action of EMface that we talked about. And as Sunil alluded to, Sebastian Codafana is an anatomist at Mayo Clinic, and really talking about how what we're doing here is enhancing tone. So really, if you think of the face as a well-worn hammock over time, where there's laxity in some of the ligament and fascia planes, and also elongation of the muscle, we're basically tightening the tone of these areas to lift these areas up. And then the next paper is really Sunil's paper that has been submitted already, that really looked at his experience using neuromodulators using EMface after neuromodulators, showing patients had an even better result and were happier with it. So this is, really great work from Sunil and Chris Robb and Yao Halas and Sebastian Codafana, looking at specifically these patients that were treated with neuromodulators and then subsequently ended up getting EMface and had even better results. I think the next picture is one of my patients that I just want to make. So this patient here, and we're in the the neuromodulator category, was neuromodulator resistant. So she had been treated with neuromodulators in the past, and then no neuromodulator seemed to be working for her. So I enrolled her in the trial. She's actually the mom of one of my daughter's best friends, and we enrolled her. And when we look at this patient here, I think we can see a really nice effect overall from EMface. And I think this is a good transition point to really talk to, Charles, if you could really, let's talk about the forehead here. So we see, the brow positioning being, maybe up a little bit laterally, but there's also a diminution in the little fibers that you mentioned here that really structurally from the frontalis are keeping the brows up. So there's more tone, but nevertheless, there's actually less lines. And this is something that I really think it's important for all of us to explain to our patients. We're not causing the muscle to contract all day long. We're just, by that one session and then repeating the session 4 to 6 times, we're enhancing the tone. And then that stimulation with the radio frequency and the monopolar RF and that temperature is decreasing the lines and wrinkles through neocollagenesis and really that neoelastogenesis, as Melanie spoke about.
Yeah, Joe, I think that's a great example. It's a great result. So over time, not only do we lose tone in the muscle, but we also have a decrease in the subcutaneous fat between the skin and the muscle. And so I like to think about that, and how I explain it to patients is now the muscle is acting more directly onto the skin. So you see more of those radids, particularly actively. And so particularly in the frontalis, there's always constant tone of the elevator muscles. And so as we get more ptosis, we need to activate more of those muscles that are elevating. You can see that patient had, before EMface, those lateral radids right above the brow. We also see that in our neuromodular patients where we're not injecting right above the brow for fear of having a little bit of brow ptosis. But if you can increase the tone and strengthen the muscle, also increasing collagen in the thickness in the subcutaneous tissue, then you see a more smooth, a more toned, and a much more youthful look on your patient. So I think she's a great result. I know you're going to move down to the mid-face, I think is even more impressive.
So the mid-face, she had improvement overall in just structural. You can see the projection of her cheekbone, the appearance that everything has sort of been moved up in these compartments and the interconnection of these compartments. So Melanie, if you want to speak to your experience in patients in the mid-face, you've been a proponent of Sculptra and fillers in the mid-face for a long time. Talk to us about how you approach these patients and sometimes even the sequence you might think of in terms of soft tissue augmentation and EMface.
Yeah, I think it's good to know like the reference point. So I would say the majority of our patients here, they like to look great for their age. We're in San Diego, it's lovely weather, but they don't want to look overfilled. They want to look that quote unquote natural. They want to just restore what their face looked like and really sort of have, how they're feeling inside be represented by their exterior facade. So In many of my new consultations, I mean, I would say early on in our experience with EMface, they were veteran patients. They're the patients that have been with us over a decade, have been consistent toxin and injectable, and we're doing energy-based devices, and we've added this on to give a little lift. In some of my new consultations, I think it's so important. I believe Natalie really sort of express this well, but I think it's so important to just evaluate the patient during initial consultation about tissue planes and where their deficit is. So we're really addressing, particularly in the mid-face, sort of volume and structure and shape that's happening in front of or medial to those true ligaments in the face. And so that's why I mentioned in my short little video, I'm okay with doing something like PLLA or an HA or calcium hydroxyapatite lateral to those ligaments if I need to kind of compress the treatment schedule. But if I am considering doing an injectable filler, sort of as a part of that treatment paradigm, I actually wait first if the patient will be patient until we actually complete their EMface series, because I see that sort of hammocking and lifting effect. You can see that so beautifully in your patient, Dr. Cohen, that I want to see how some of the tissue readjusts, because we see that nasolabial fat pad sort of readjusting upwards. You see smoothing, and you lose some of those demarcation lines that we start to see in the aging face and mid face. And I want to see how the cheek and the OG curve changes, how the depth of the piriform fossa or sort of medial nasolabial fold is being affected. And so many women in our 40s, this is the problem, that descent of the buccal fat pad and the prominence of jowls. And I find that we're improving that. So the way I'm injecting and the volume I'm injecting, I think, is being affected in sort of that mid-face, where usually we're using projection as a way to utilize fillers. But I feel very comfortable if there's volume deficits in the superficial temporal fat and the preauricular fat, or there's bone loss in the angle of the jaw, as Sunil, as Dr. Chilakuri mentioned, then I feel okay doing that in tandem.
So in overall volume. So again, for me, I approach it from a structural standpoint. What fat pad is being affected, right? You talk about the fat pad. If you talk about the lateral zygomatic area, if you're talking about the middle fat pad, the nasolabial fat pad, if you're talking about where the maxillary bone is sitting. So if it's starting to recess, I'm going to put those structural points in there at the same time that I'm utilizing the EMface. And really, because from a clinical standpoint, I want that patient to see that wow. So I do utilize that either in that same treatment session or somewhere in between as we're treating the series of 4. The temperature of the RF in this particular device, it's going to be more superficial. So we're not trying to radiate that heat deeper. It's not that bulk heat that you're seeing. So we're staying in the superficial, really the mid dermis is where we're aiming for that heat. And you're in an area where you're getting to 42, 43 degrees, maybe 44 max. And if you look at if you have the EMface unit, you see it gives you real-time feedback on it. So you shouldn't be getting much above that. In terms of the temperature melting points of most of these products, Bellaterra actually, as far as I know, has one of the lowest melting points. So that's 171 degrees Celsius versus what we're putting here, which is 41 to 44 degrees maximum.
Dr. Palm, as the resident sculptor here, talk to us about what's going on in terms of sculpture underneath, because I have no problem with putting EMface directly over an area that I've augmented with sculpture as well.
Yeah, I don't have a problem with it at all, because I think our target for Sculptra is either super periosteal, which is obviously several layers tissue-wise below where we're targeting that very superficial heat in the mid-dermis, as Dr. Chilakuri mentioned, or it's in one of the fat pads, typically a deep structural fat pad if I'm working in the central mid-face, a superficial fat pad, if we're working in sort of the lateral face. So again, I really don't Some gentle heat and neocollagenesis we know is one of the end results of the radiofrequency component of EMface. I think of it as very complementary, and it's certainly not going to break down the polyl-lactic acid in an abnormal fashion.
Dr. Boyd, there are many ways that we can enhance the jawline, and you can see like a really crisp jawline here, but on the next slide is a patient who's a decade older, and this is, I think, a great result. The patient's a nurse. The pandemic and taking care of kids has been, really tough on a lot of people. And this was an outstanding result for her. So when you're talking to people about sort of that neck jawline rejuvenation, this is a great result. Tell us how your consultation's going and how you really incorporate EMface into that.
Yeah, I think it's an amazing result, Joel. I think that, and this is a great example of what we're trying to achieve even with the surgical lift. And as you can see, even though the electrode is targeting the zygomaticus muscles, obviously the SMAS envelops the platysma. And so as you're elevating the SMAS, right, you get more sculpting of the jawline. You see the submental skin looks improved. Even her chin looks improved in this. And so this is a good example of how all the facial musculatures are from the top of the SMAS down to the platysma are in sync. And so as you're elevating those upper facial muscles, you're also elevating the SMAS, you improve the neckline, and this is a quite amazing result. Even the angle of her jawline is improved there. So it looks like you've contoured that area as well. So when someone asked before in the discussion, how do you incorporate this with surgical patients? But this is something that I would love all my facelift patients to have EMface first, because if I'm working on a tighter, more toned muscle, I'm going to get a better result even with a rhytidectomy.
So Dr. Fournier, you indicated in the video before this session that you have a lot of energy-based devices in your practice. So when you look at a patient like this in the pre-photo, sort of what is running through your mind in terms of the options? And then really when you guide patients towards those options, really what do you start thinking of in terms of specifically the jawline and trying to get a really clear-cut jawline like this?
Okay. If I had this patient in front of me, I would offer a program which will include something for the structure of the skin, like the microneedling radiofrequency, just to improve the skin tone and also the skin structure. So you can use the Excion on it, for instance. I will include also in the program the EMface, about for me 6 sessions minimum, because due to the age, my program 40 years old, 4 sessions, 50 years old, 6 sessions, 6 to 8 sessions sometimes, and over 60s. And then a maintenance program every 4 months if you are over 50s, and every 6 months if you are less than 50s. So I will offer that 6 sessions of EMface, and of course I will probably help her a little bit on the neck with monopolar radiofrequency, and especially the small handpiece for the Excion, the ultrasound and radiofrequency, and I will also maybe use a little bit of fillers, not on the jawline, but maybe on the cheek if necessary, just to make a little more projection. And I will see after that, when I mix all this, how she will become, and then I will adapt the treatment.
So, when you're talking to patients about the overall benefit of combination therapy, in terms of your overall sequence, I think you explained very nicely that the patients that had neuromodulators before benefited from having EMface. In terms of, sort of that next step, you have a lot of different devices, BTL devices in your practice. Talk us through sort of maintaining results and giving people sort of that blueprint of what they can do over successive months.
Definitely. And thanks for the question. That's a fantastic question. We have a lot of devices. We have 52 devices in our practice right now. We just added a 53rd this past Friday. So it's always a question of how do we utilize these? Any device that we don't use for more than 6 months, we either sell it off or we give it to the VA or we give it to the resident. So the device that we have, we use in combination. Let's say for the lovely lady that you have in front of us, this 49-year-old woman, she got great results. I'm not sure if it was 4 treatment sessions, 6 treatment sessions. I presume this is 3 months after the last treatment session of 4. Joel?
Correct. She was from my site's clinical trial, so this is 3 months after the 4th session.
Let's utilize her as an example. If this is a patient, she already trusts you. If I'm in your shoes and she trusts me, what else would I do to enhance her results? For a maintenance type protocol, using the Exion, we know, and we finished that clinical trial, and I think it's already published, where we do the difference between using, let's say, Exos Ultra, which was a combined ultrasound unfocused with the RF, versus what we have with the Exion, which is going to be a focused ultrasound, not microfocus, but focused ultrasound with RF. And we saw there was significant improvement of collagen and elastin. So how can I maintain those results, especially even enhance those results? Let's say for around her eyes, I would add Exion. We're going to be able to tighten even more. In her case, I can also use RF microneedling for the lower lids or even upper eyelids if she has that crinkling when she has dynamic motion. So just from the tissue pushing upwards. So I think that's a way that we can enhance. From a filler standpoint, if you look at the oral curvature, can we give a little support structure using your favorite HA? For the back of her jawline here, you can see there's just a little bit of, at least from the photo, it looks like there's a little shadowing over the anal-gota notch. So maybe we put some structural support with whatever your filler of choice or collagen stimulator of choice is along the angle of the mandible, and maybe go more mid-dermis or superficial dermis to address the little bit of depression that's there. So that's how I would utilize it.
So,
Hey, Joe, can I just add on to that?
Yes.
I think the other thing in terms of Exion that's so nice, particularly about what we found with that study, was that it greatly increases hyaluronic acid in the skin. And so particularly around the eyes or other areas that you need to plump up the area and add hydration, it's an amazing result there.
So I just want to
backtrack as well.
I just want to backtrack. Exion just got launched at the American Society of Laser Medicine and Surgery. So for people who aren't familiar with Exion, it's a new platform from BTL, and it has RF microneedling and bulk radiofrequency for face and body. And then it actually has FemTouch 360 as well, EMFem. So it is an exciting platform for BTL, and we're excited to see a lot more from that platform. If we can look at the next set of photos, and Dr. Palm, when we talk about, patients and getting older, you have a lot of patients with sun damage. You have a lot of patients who really want that healthy lifestyle. This is a 78-year-old guy who was in my clinical trial. And I think you can see that he's had some nice improvement. Obviously, he may have been sort of thinking at some point along the way to seek out somebody like Dr. Boyd and have a facelift. But, for a guy who really didn't want surgery, didn't want downtime, he was able to get a nice result. So can you comment on this type of approach and what you would do for this patient?
Oh, sure. First, topical skincare. I hope he's using sunscreen, but we want to make sure his extracellular matrix is healthy and that he's not kicking out a bunch of MMPs and collagenases and other enzymes that are sort of like a bad downward drain soup that doesn't allow him to really exploit technologies that are energy-based technologies to their fullest in terms of their neocollagenesis and neoelastogenesis propensity. So I think that is definitely something I would talk to him about. I think you've done the perfect first step, which is giving that sort of SMAS and mimetic musculature layer a pep and helping to lift that. I think step 2 for me would definitely be some form of structural filler or collagen stimulator, because we know we can improve that remaining jowl that he got quite a degree of improvement from with that. And I'm looking back, he does not have the strongest jawline. I'd want to see some photos of what he looked like maybe 10 or 20 years ago, talk to him a little bit about that. But I think that would be an area of focus, along with a little bit of the superior chin, I think, would benefit along with some of that jawline work in that area. You know, I like a nasolabial fold. I don't want to eliminate it, but you know, I'd want to see how that improves with midfacial and lateral support. But if there was a little bit of improvement necessary starting at the superior pole of the nasolabial fold, I'd probably help some of that structural bone loss that happens. And then, you know, superficially in the fat, I might help that out a little bit. And the same with his marionette lines. But I love your approach, Joel, where you treated first kind of the skin envelope in the muscular layer, and then sort of addressing some of that volume loss second.
So, you know, just as a little background, all these patients have a story. And this patient, first movie I went back to with my wife to resume date night after COVID. We were at the movies and we saw Where the Crawdads Sing. The lights went on and I was literally sitting next to one of my longtime patients, and I'd never met her husband, and he's her husband. And she said, "Hey, what's new? What's going on in your practice?" And I hadn't seen her in a couple of months, but she had enjoyed the benefits of many injectables that we had done over the years and other procedures. And I said, "Wow, we've got this new device we're doing a clinical trial on. I can't say so much about it, but it is pretty exciting." And she said, "Can I be a candidate?" I said, "No, there's an exclusion, you know, so you've had neuromodulators and fillers, so you can't do that right now." And her husband came out of nowhere and he said, "I'm interested." So this is him. He'd never done anything before and he was really quite impressed. So, you know, Natalie, you indicated, you know, from a laser perspective, you do a lot of lasers. What would be sort of the next step that you would do, that you would think about in this guy where, you know, he's already enjoyed the benefits of EMface, and I look at him and I see pigmentation? I would probably get out my Halo and my BBL Hero and use that on him. What would you do?
Yeah, I would maybe first check very clearly if he has no keratosis. And in this case, I would do a photodynamic therapy, one session. And then I will do probably an IPL session just to remove the pigmentation easily. And then I will go for Fraxel CO2 laser, probably 2 sessions, plus mixed with 3 session of microneedling radiofrequency with the X-ion. And then the structure of the skin and the aspect will be very far improved from that. So if he wants to go through all that, he will probably get a better result. And then if he doesn't want anything more than non-invasive, I mean big invasive treatment, I would do, okay, let's try to do monopolar radiofrequency, at least for the neck. And I will add, of course, if he accepted, some injection like Profilo, or I don't know how you call it in the US, but I guess it's the same, just to smooth the neck, you know, not for the face, but to smooth the neck. And,
so just pointing out the neck, you know, I think it's exciting when we really see the results in the face and in some of the volume compartment areas when we see enhancement of the jawline. You know, Charles, you mentioned the SMAS, and I think this is a really good example of that overall tone of the SMAS has actually enhanced some of the neck as well. So will you speak to sort of anatomic planes that can lead to that and how that tone is affected here?
Yeah, absolutely. You can see that particularly just below his jawline, where the laxity in his neck is greatly improved. And so I think the neck is, I would say, the hardest thing to treat. So certainly in the upper face, we have a larger soft tissue envelope with the SMAS, and then we lose that as it starts to envelop the platysma muscle. So, you know, if you were to lift back the face and start following the SMAS, you follow it right into the platysma. But that's a fairly thin muscle, and the skin is right adjacent to it. So that's an area where I always tell my patients that the earlier and the sooner we can do things to lift and tone that area and prevent either solar elastosis or just loss of elasticity in the skin. And you can see as the platysma starts to go more anteriorly, it needs to be pulled back posteriorly. And so EMface is a great treatment for that. You know, I agree with all of my dermatology colleagues on here. Certainly Fraxel or BBL Hero would be perfect. but I still want to do a short scar facelift on this guy and just take it home.
Melanie, from your experience in doing the work with EMface, what can be really the durability of a response like this?
Yeah, I think that's such a good question. I saw, Joel, there were some questions about like who's a good candidate and maybe who's a poor candidate. I think youth is always on your side in terms of number of sessions. And I think we've heard Dr. Fournier say the same thing. She has sort of a stepwise fashion of, on average, how she treats patients as they march through time, age-wise. And I also look, and this is something I think JD McCoy, who's also a BTL luminary and has had some early experience with EMface, recognized too, that people who actually have good volume in their lower face tend to respond well. If they're very cachectic in that area, I'm a little bit more conservative in some of my expectations for the patients, and I convey that during the consultation. And just in terms of sort of maintenance, what we've done for most patients is similar to what we've done with some of the EM technologies. So we have said quarterly would be best, but I want to see at least twice a year to maintain the results. Of course, we have superstars that want to do it a little bit more frequently than that, and I think that's reasonable. And we try to make maintenance therapies enticing from an economic standpoint, so we give them a little bit of a discount for maintenance therapies.
So David Ruckert's asking a very good question about maintenance treatments. And Dr. Boyd has been doing EMface treatments longer, I think, than any of us. You started your clinical trial earlier, and your clinical trial really focused on patients who may have really come in thinking about surgery. So obviously they had quite a bit of laxity. They ended up doing EMface. And your experience in terms of durability, I know we've seen some pictures from Yao Halas, who's had really improvement that she can document out to a year. But in my patients, I say to patients who are a responder, look, you had a really nice response. We have really good data at this point from my clinical trial and others that the people who've had a good response, show that type of response 3 months later, 4 months later. I do think there's a bit of an attenuation of that response at about 6 months. So we can do maintenance like gym membership type programs to give them sort of a maintenance treatment perhaps every 6 months. So what is your experience, Charles?
Yeah, thanks, Joe. I think that, I certainly have patients that are 18 months out from their original trial, and they still look better than they did prior to EMface. And so I think I tell them that the jury is still out. So I generally tell my patients that I have patients at least 18 months. I really do encourage them to do maintenance. And I think the gym analogy is one that I use commonly. If you go to the gym, you can certainly work out really hard, but you still need to continuously stimulate those muscles to tighten them and keep them and to maintain that tone. So we have them on a program where we do maintenance, usually at least quarterly. Again, as Melanie mentioned, some patients do it more frequently than that. I think that I'm actually, even in the first consultation, we're often treating them kind of like I do sculpture patients. So I generally say, well, you might need a treatment per decade of life. So if they're 50, I tell them about 5, 66, 77 treatments as that initial baseline. And so I think that's one of the things that we're doing. And so in terms of the longevity, I think that, those first patients, at least 18 months in my practice. And so we'll see as we go on in the study.
I think that's incredibly exciting that you've seen 18 months because, Yao's pictures at even 12 months where she just continued to follow a patient, you can still see some bit of effect. So that tone is really helping to reestablish for quite a while in those pathways. I think that's a great segue to really talking about some unique circumstances that we've seen in some patients, and people have reported some patients who have Bell's palsy, who all of a sudden have better symmetry. Has anybody treated a patient with Bell's palsy? I know we don't understand exactly the cause and it's idiopathic, but Sunil, talk to us about your experience.
So we actually have 3 Bell's palsy patients that we've been treating, and then we have 2 CVA patients, so stroke victims, with really pretty significant improvement. So typically the side that's affected by Bell's, especially if it's more than a decade, that side, the tone is increased. So the side that hasn't been affected is actually fallen down more, if you want to say it's fallen or looks fallen. So we can adjust, because based on the EMface itself, you can adjust each applicator individually. So you can adjust both the high Fez as well as the RF. So for those patients where we're trying to pick up, let's say, improve the tone on one side, I will increase that high Fez to 100%. Let's say it's the left side is lower. So I'm going to increase the high Fez to 100% here while I'm using RF at 100% on both sides. I don't want to activate the other side unless we're going for a specific indication. We've also done this for significant asymmetry of the brow, where you can see that, let's say the right side is sitting a centimeter. I've got one patient where she was 1.3 centimeters lower, and now the difference is 0.3 millimeters. So it's very significant improvement of the brow position. And that we've seen the brow position, especially if you continue with your neuromodulators to kind of adjust that. It's lasted, she's now 16 months out with great results.
So Melanie, I know you've been involved with the Emsculpt Neo projects for many years, and you've done much of the work and have published this and presented this. We get a lot of questions sometimes about high fem in Emsculpt Neo versus high fess in really EMface. So can you sort of delineate that for us?
Sure. I mean, I explain to patients these are kind of cousins. They're not the same, though. So, we're causing involuntary contraction of the musculature directly with high fem technology, where it's more about depolarization with high fess technology. So I think that's really important to make clear with patients. I'll tell you, for our body work, and I'm curious to see from the other speakers, the majority of our work these days, even though we have Emsculpt and Emsculpt Neo, we love combining Emsculpt Neo. Not only does it, pre-warm the muscles for the high fem treatment, we see, increases in the fat reduction when we actually do that. And then just anecdotally, we see improvements in the skin texture. So I think it's really important to explain to patients the difference, that you can think of them as somewhat, unrelated cousins, but it truly is different technology that we're using on the face versus on the body.
That's great. Thank you. I think this is, Charles, this is one of your patients, and this is something that we definitely see. And I think that even if we don't have a 3D camera in our practice, I think having your pictures to show patients that there is a volume change that you can see. And what's really happening here in terms of cheek volume is, after EMface treatment, there's actually about 1.5 cc of filler type of appearance. So can you speak to this result here?
Yeah, I think there's so we know there's a line of ligaments that go along the face, from the jaw to the temporalis. And we know that as you lift and add, even if you were going to do it with a filler, this anterior to that lateral line will increase projection in the cheek. And so lateral to that increases lift. And so what we're seeing here in this EMface, and this was done with a vector camera, that EMface alone added about 1.5 cc's of increased projection, and that is represented by the blue. You can see the yellow and the red actually is a decrease in, it's not really volume, but because it's lifting up, that volume that was lower in the face is now elevating in the face. So the face looks lifted. It looks like the patient has had filler, or she just looks more youthful. I think that, as Melanie mentioned, a lot of patients are trying to kind of have less filler, or certainly that look, but we do want that youthfulness where we have that more heart-shaped face, where it's fuller at the top and less full and more angled along the jawline and lower face. And so this is one that I show all the patients in terms of what results are possible with EMface.
So, and thank you. So can we show the next picture? So same type of thing. This is, you can see the volumetric, but this is Yao Halas at a year, really showing that there's continued improvement. You can see the jawline definition. And I think it's really enhancing the tone and the interconnections of all these little ligaments and fascia planes and the elongated muscle, lifting it up. This is a patient from a clinical trial who was followed, no other treatments over the course of a year. So when we're talking about durability, I think this is exciting if patients are doing this as a standalone treatment. And as we said, many of us are doing this, in combination, whether we're doing EMface first and then going to areas where they may still have some volume needs, or we're doing the EMface over neuromodulators and fillers. So I think when it comes to combination therapy, we're getting some really good questions, Dave.
I am doing the face and the body, but successively. I mean, so it takes an hour instead of 30 minutes, but it is safe and you can do it. Many patients are doing this in my office.
So having water for your patients on hand is important. People talk about hydration. Sunil, you're answering some questions about hydration, so I'm going to let you take that from here.
Yeah, I ask my patient to drink before and after Scalp Neo especially. And EMface, usually they ask for some water after, because due to the heat they want. So yeah, I offer a little bottle of water to every patient who come to my office after the treatment. We cocoon them,
And I agree with Dr. Fournier. One of the most important things about radiofrequency, the way that it works, it's generating a positive negative. So that positive negative polarity is what's going to affect the water molecule, which is also positive negative. So when the positives get closer to each other, it'll start rotating that water molecule, which is what's going to then account for the heat that's being produced locally. So hydration in the skin is extremely important. When we were seeing early results with Vanquish, that's 2015, 2014, when people didn't get great results, and we actually checked how they were hydrating, that was internal water intake. It was a big difference. We saw when people were drinking the night before, drinking the day of, or drinking the day after with alcohol, they were getting more dehydrated. We weren't seeing the same effect. In terms of the skin, there's a couple of things that can be done. If you don't trust it, the easiest thing to do, honestly, is to download the BTL app. So we make our patients actually download that app in the office when they come for the consultation, and we can track their water content, especially if we're doing body contouring. I think it's more essential. For the face, we do take a screenshot of that when they come in for the EMface treatment. But if somebody's not perfectly hydrated, we can actually apply a topical HA. So the product that we use is Hydrinity, and it has both long and short chain HA molecules. Apply it on, wait for about 10 minutes, talk to the patient, take photos, etc. And then we apply the EMface applicator. So that immediate infusion of the hyaluronic acid there does have a temporary effect of water being pulled into the skin. And we're seeing greater results with that. Not just from the high fez necessarily, but more from the skin texture and tone and the luminosity that we see at the end of that result. And we did a small in-office clinical trial treating 12 patients with only one side being treated with the Hydrinity and then applying the EMface applicator, and the other side not having anything, just with whatever the patient did with their normal skincare routine up until that point. And we showed that there was increased luminosity, and it's hard to measure because we're really measuring the elasticity of the skin, but they look brighter in person. And then in terms of the elastometer, we saw that there was an improvement of the overall elastic tissue that's there.
So I want to point out, we've had a great session. We've talked about incorporating EMface into our practice, how EMface works, how EMface can be used in combination with other things that we do in our practices, from neuromodulators and the synergistic results Sunil saw, to using it with fillers and the volume replacement Charles saw in his study, and Melanie's sort of thoughts on using fillers in conjunction with this and Sculptra in different areas. I just want to get a sense of where everybody is in terms of excitement for the next phase of EMface. And at least for me, with Exion's approval and having RF microneedling in a BTL platform, I'm excited to use Exion in combination with EMface. So Dr. Fournier, let's start with you. What are you excited about the next phase for EMface?
I'm excited that this will be a kind of entering aesthetic, a gateway procedure for young people without harming them, and like a kind of act of rejuvenation, so preventing age before it's coming. So because they smoke, because they don't take much care about themselves, this is an exciting thing, because really we can treat young people without fillers, without offering also neurotoxin, and this is good for their health. So that's the main thing about this device for me. EMface will be the machine for the young people too. And the second thing is that really the combination, I tried that already because I got the Exine for a while, and really it's working. It's the combination of these two devices improve the structure of the skin and really the tone, and the EMface does it works. So it's really a good combination of the both device.
Same question for you, Melanie. You're working in California. You're seeing patients who Natalie indicated, healthy patients out there. So what are you excited about?
I mean, I think, as I've mentioned previously, just this idea that we're sort of rehabbing some of our own tissues is so appealing. And I think we're just at the beginning crest of how this falls. So I think for me, it's combination treatment and using this as a way to really target the SMAS and the musculature. I mean, I do myofascial release with my physical therapist to keep my body in good shape once a week. And so I think of EMface as sort of that similar respect for my face to really keep that tissue envelope in good shape. And then I think combining it, doing things that are also promoting in sort of parallel collagen formation, elastin formation, whether that's things like PRP and PRF, collagen stimulators like calcium hydroxyapatite and PLLA. But I think also I'm really happy. I've got almost a 5-head, as you can see, but we're going to have a small applicator soon. So I think we've had challenges with a couple patients having more petite foreheads. And it'll be really nice to have sort of a more bespoke approach to treating the frontalis with that smaller applicator.
So, and Dr. Boyd, I see patients all the time who I have no problem with referring on to you and my facial plastic and general plastic surgery friends and colleagues. But one of the areas that I think that is exciting is looking at patients who've already had a facelift and that they're starting to have a little facelift fatigue. It may be 5, 7, 8 years later, and incorporating EMface into those patients for a little bit of a tweak. And I've seen nice results. So where are your thoughts in the future of EMface?
Yeah, it's something we're doing now. I think that generally after a facelift, we say usually about 5 to 7 years is when they'll start to kind of see some of that descent. It's a perfect time to put them on EMface. I think it's a perfect time to do the EMface Exion combination. So when I think about EMface and toning the muscle, and then when you think about as we lose hyaluronic acid and the skin starts to kind of thin, Exion is a great treatment with both the microneedling component as well as the ultrasound and RF component works really well. So I'm super excited about my post-surgical patients to use those as well. And Melanie, I'm in San Diego this week, so I might need to get your body person so I can get my whole myofascial tone together too.
And then wrapping up with, Dr. Device over here with 53 devices now in your practice, Sunil.
How many did you get rid of if you kept 53, Sunil? That's
So, Sunil, what are you excited about in terms of the future of EMface?
In terms of the future, I think it's really interesting to put clinical trials in front of everybody. So how are we combining this with RF microneedling, whether it's Exion or otherwise? How do we do with bulk heating with radiofrequency ultrasound? How do we utilize it with our resurfacing? What's the safety that we have with fillers, HA fillers or collagen stimulators? Is there an ideal time frame in which to apply these other modalities? Can we use this with plasma or helium technology to shrink wrap that skin after we do an EMface? I know clinically in practice, all of us are using these combinations. I don't think we have a definite answer. Is it better to do this first or that second or whatever the order is? So I'd like to see where we're going with that. But I agree with what everybody has said. Dr. Boyd, for me, when somebody comes post-rhinectomy, and it can even be 10 years after a facelift, 15 years after a facelift, we get faster results by applying the EMface, where they just get this, because again, the muscle is shortened, so it makes sense, right? So there's less surface area of that muscle to contract and create tone. So I'm excited to see where this goes, and not to put you out of business, Dr. Boyd, but the question always for me is, continue to maintain somebody who's in their 20s and look the same in their 70s, 80s, and 90s. That's our goal. So everybody wants to look like Dr. Cohen and Dr. Palm and Dr. and you. So that's the ultimate goal for me.
Honestly, I've seen such nice results in so many of my patients, but when people look at my wife or my mother-in-law who've enjoyed the benefits of having EMface treatment as well, results look natural. We're able to really pinpoint areas that we can do other things like fillers and do neuromodulators or work on dyspigmentation or color issues. So I think the future of combination therapy and incorporating EMface into our treatment regimens is very exciting, and seeing durable results from Yael is great, but really we realize, as Charles pointed out, that people do need to have maintenance treatments, and whether that's every 3 or 4 months or every 6 to 8 months, there are really maintenance sessions that are going to help people enhance their tone. So thank you very much for our panel for joining us today. I hope everybody has a great rest of their day, and we appreciate all people who've joined us accessing this BTL program today. Thank you.
Thank you, everyone. It was a pleasure to be with you, really.